Elliot will be doing his talk on updates in heart failure management. Welcome, Dr. Elliot.
Thank you very much, Dr. Mead. Let me share my screen. And again, I thank for the opportunity of sharing this. I was asked to share on heart failure, what is new in the management. And I could tell we could spend quite a bit of time talking here, but it is quite a lot which is happening. And the truth is, I am somewhat excited with what has been happening in the field of heart failure recently, or let's say over the past few years. And I listened to some of the talk before and heard some things on the RNA and the SGLT2, which will make things a little easier for me. So let's get on this journey. So I have no disclosures, nothing to declare in terms of conflict with this talk, except that I know Dr. Mead. So heart failure is, just to put in perspective, it's a condition which is actually worse than many cancers. As I've seen here, your 5-year death rate in heart failure approaches basically 50%. And there are many cancers which you can, in today's world, live with longer than 5 years. As a matter of fact, a lot of cancers are now being considered as a chronic disease, as opposed to the fast kill that a lot of people have in their minds. You know, you get the big C, you think you're going to drop dead in a few weeks, but you live many years. There are people with heart failure who do not even live beyond the first year. What is our goal for heart failure? So there are certain things which I want to bring into focus as we talk about the new management and what it is as physicians we are aiming for. So what we're aiming for is all interrelated. We want to reduce heart failure related hospitalization. We want to improve symptoms. We want to improve the overall health of our patients. We want to improve their functional capacity so that they can do more and get back to active living. And of course, overall, we want to improve survival. We want to reduce mortality. And to do all of that requires proactive clinical care. You know, you had asked in terms of one of the things to say about COVID, and I didn't get to speak, but there's one thing I would want to just interject here because it's somewhat related, is that the healthcare persons who are putting up opposition are actually affecting this part. They're not being proactive in clinical care, and we could debate many ways about that. And it is happening in other conditions such as heart failure. So as our goal, everyone who is here, irrespective of your speciality, you are playing a role in this cycle. And so we are asked to be proactive. One of the things that is, well, this slide shows a few things which are very new in terms of heart failure. First, it has been redefined. Many of us in medical school may have heard a definition such as heart failure is the failure of the heart to meet the metabolic demands of the periphery, or does so with an elevated diastolic pressure. But then they found that there was a little problem. How do you know the metabolic demands are not being met? Suppose the lactic acid levels are normal, the bicarb levels are fine, the pH is okay. So where's the metabolic abnormality? And so they found that, along with other things, the definition was not quite bringing in what the problem is. So the current definition, which has been agreed by all the bodies, ESC, ACC, Canadian, European, Asian, African, they have all come together with this definition, in which it is a clinical syndrome in which you either currently or prior had symptoms and signs called due to a structural or a functional cardiac abnormality, along with either having elevated natriuretic peptides or objective evidence of cardiogenic, pulmonary, or systemic congestion. Sounds like a lot, but think about it. It really is what you have been doing. So you know there's some form of cardiac injury, functional or structural, with what we would consider the clinical signs and symptoms, either pulmonary congestion, systemic congestion, pedal edema, elevated JVP, liver congestion. But they have also added, while you may not have that, but if you have a natriuretic peptide elevation, you're talking about BNP or pro-BNP. So all of this in collaboration. So you need, it's like an A and one of B to be able to define somebody as having heart failure. The second thing is the stages of heart failure. Now, a lot of us have heard about stage A, B, C, and D. And that came about years ago, first initially by the WHO. And I love to share what they have in that paper, in which they said the staging came about not for patients, but for physicians to come to a realization that heart failure is a chronic illness, and that to use the term that the patient is out of heart failure is an erroneous term and must not be used by healthcare professionals. Now we have gone further and we have now redefined these stages. So what was stage A is now what we call at-risk heart failure. So you have a condition which, if not controlled, can damage the heart or make you have some aspect of this syndrome. So if you're hypertensive, everybody who's born with sickle cell disease, for example, or if you have developed diabetes, you may be at stage A. You are at risk because you have a condition which can cause a problem. Then you have stage B, which is what we call pre-heart failure, in which there is now some form of evidence of structural heart problems, functional heart problems, or you do actually have an elevation of your natriuretic peptide or your troponin, but you have not presented with any of the classical symptoms or signs of heart failure. So you have not been symptomatic, but there is some damage. Classical example, person with hypertensive heart disease who may have some left ventricular hypertrophy. That hypertrophy is a bit of damage due to the hypertension, but they may never have had any of the congestive symptoms of heart failure. Stage C is what we know as heart failure. You're symptomatic. This is where you now talk about New York 3, 4, and 2 signs and symptoms. And then you have advanced heart failure, which, notice what it says, it's severe, having symptoms at rest, recurrent hospitalization despite being on guideline-directed medical therapy, but you're now requiring advanced therapy, example, transplantation or some form of mechanical support. Now, the previous definitions of these stages had that if you went from stage A to B, you couldn't go back to A. If you went from B to C, you can't go back to B. So once you went down a stage, you were considered to be at that stage and permanently at that stage unless you went to the next stage. Unlike the New York Heart, which is a symptomatic measurement in which you can change how symptomatic you are. But in this new definition of the stages, it is true. If you go from A to B, you can't go back to A. If you go from B to C, you can't go back to B. But you can go to D and come back to C. So C and D are reversible in that once you're at D, you do not have to be permanently at D. But also realize they are still keeping the concept. If you reach heart failure, stage C, you cannot get back to B. You cannot say to your patient that they are out of heart failure. A part of this now comes with this new classification of our terms. When your ejection fraction is less than 40%, we say you have heart failure with reduced ejection fraction, or what we like to say, HFrEF. If your ejection fraction between 41 and 49, we have heart failure with mildly reduced ejection fraction, or HF, Mr. F. If your ejection fraction is above 50% and you have heart failure symptoms, what we will categorize mainly as diastolic dysfunction, we now say you have HFpEF. Now, if you have been at a HFrEF and your ejection fraction increases by 10 points, or you get an ejection fraction above 40%, we will say you have heart failure with improved ejection fraction, or HFIMP-F. Yes, we love these terms. But notice the terminologies, and this is what you'll be hearing as you hear people talk about heart failure. HFrEF, HFpEF, those are the two main terms. But one thing we want you to know, there's no such thing as stable heart failure. None. Stable heart failure is a misconception. It's a misperception. There's no such thing. Nada. Just not there. So even that patient with HFIMP-F, that patient who seems to improve, even though they're showing that maybe at a New York Heart 1, realize heart failure is a progressive disorder. It's the same way how you conceptualize that a person may have, say, prostate cancer. It has a metastasized. You don't put up your head and say, hey, they have stable prostate cancer. No, you're always monitoring them, watching their PSAs, watching for if there are any metastases. They're always going to be on some treatment. There's no time at all do you ease up to think, oh, they have stable cancer. And remember, heart failure is worse than most cancers. So that concept is gone. So instead of saying stable heart failure, you will use terms like persistent heart failure. If they have improved and seem to have recovered, we say heart failure in remission. Almost the same thing like what we do with cancers. Very rarely today do they say that their cancer is cured. They will say you're in remission. The truth is, even with cancers now, they're starting to use the term cured for some. You can't use it for heart failure. And again, I mentioned, you may say they have HFIMP-F, they have improved, but guess what? It is still heart failure. So just get that concept out of your mind. No such thing as stable heart failure. When we look and see why is it that patients with heart failure get readmitted, one of the greatest reasons is that they're not following guideline-directed medical therapy. And as this chart shows, those who are not on guideline-directed medical therapy have a higher mortality. They get hospitalized more. And so this is a push to tell us we need to get our patients on guideline-directed medical therapy. I just want to show you this because this is for us, the healthcare workers. If we want to improve our outcome with our heart failure patients, the whole thing of randomized controlled trials and the discovery of drugs, etc., is just the first step. We need to get that knowledge out to who? To us. And we need to, after getting that knowledge out, translate that to the actual care of the patient, and then to have deliberate implementation of these therapies. And you know what has been shown? There's actually a study which showed from that first point to the last point, on average, takes 15 years. What it means? It takes us 15 years to convince healthcare workers from the clinical trial to the point in which it becomes a daily occurrence in how we treat patients. Let me even give an example. Look how long ago the paradigm studies came out showing the benefits of Vemada. Yet over 10 years ago, and today we still have physicians who are reluctant to prescribe Vemada. That's just an example. We want to sit and watch and see. We want to wait. Are there any side effects? Let me wait and see what happens in the real world. What if this drug is going to be recalled? Let me wait on the experts to use the medication before I start to prescribe it. Kind of sound like vaccines on COVID, doesn't it? But we have to overcome this inertia, this clinical inertia that we have among healthcare workers. Because if we're not getting our patients on the guideline-directed medical therapy, it's our patients who suffer. Let's just talk a little bit about what happens with heart failure so you can understand some aspects of how we have to direct our treatment and the new aspects of treatment. We do know that the sympathetic system and the renin-angiotensin-aldosterone systems play a big role in what happens with heart failure. In short, they induce what we call remodeling. They stimulate proteins that create things such as fibroblasts and cause fibrosis. It induces hypertrophy. It causes, they activate growth factor matrix metalloproteinases. They cause vasoconstriction, water retention, resulting in what we see as the congestion in heart failure. These systems cause myocardial slippage, meaning that if you remember from your physiology, when those myocyte heads hold on to the to the fibers, you cause slippage. So that syncytium starts to loosen, and so it leads to the dilatation of the myocardium, as well as cause oxidative stress and start to have direct cytotoxic effect and promote apoptosis. Understand, when you have heart failure, your levels of adrenaline, noradrenaline, renin, angiotensin 2, and aldosterone are elevated above normal. And it is these elevations which create these effects. So what really is therefore defined as cardiac remodeling? It's a group of molecular cellular interstitial changes, which I've just mentioned, which manifest as changes in the size, mass, geometry, and function of the heart. An interesting thing about the heart, we know the heart has this kind of boot shape. You know, the heart, when it contracts in 3 axes: longitudinal, transverse, and rotational. And medical physicists will tell you that boot shape of the heart is the perfect shape to get all 3 axes working together to give you the maximum contraction and output of the heart. And if that is so, therefore, any change in that shape means you're losing efficiency. And remodeling, which I remember causes slippage, dilatation. It causes hypertrophy, which means you start to lose that shape. And the moment you lose that shape, you start to reduce efficiency. Remodeling is associated with arrhythmias, which we know causes poor outcome in patients. And there are 2 types of remodeling: physiological, which is an adaptive, which tends to occur in things like our athletes, in which that remodeling is done to try and improve output. But then we have the pathological, which occurs with heart failure. And again, this is one of the reasons why heart failure is a chronic problem. Because once you get that elevation, okay, let me just take a step here and explain. When, for example, God forbid, you're in a car accident and you hit your chest against a steering wheel hard enough to cause myocardial stunning, that fall in the cardiac output stimulates your adrenal glands to increase your adrenaline and noradrenaline, as well as it stimulates the RAS system to increase angiotensin and aldosterone, to retain water, vasoconstrict, stimulate the beta receptors on the heart to get cardiac output back up. As that myocardium recovers from the stunning and is now able to take over function on its own, these neurohormonal levels come down and you go back to normal. But if you take a patient who, for example, has an MI and lose their anterior wall, their cardiac output falls. That fall in the cardiac output stimulates the rise in adrenaline, noradrenaline, and your RAS system to stimulate the heart to pump out more, vasoconstrict, retain water to get proper circulation. And it does that. The cardiac output does improve, but it doesn't come back to normal. And the only negative feedback to this increased secretion is a normal EF. So not being normal, the levels rise some more because their objective is, let me get the EF to normal. They rise more, more water retention, more vasoconstriction, stimulating the heart some more. You start to get a bit tachycardic. The cardiac output is still below normal. So what happens? It even stimulates more. But now you start to get high levels which become toxic to the myocardium. And as you saw, as I explained, it becomes cytotoxic and you start to get apoptosis. So you start to lose myocytes. The loss in those myocytes causes a fall in your cardiac output. That fall in your cardiac output stimulates the adrenal gland and the RAS system to increase more neurohormonal factors, which are more cytotoxic, kill more myocytes, cause a further fall in your cardiac output, which stimulates more neurohormonal levels, which are even further cytotoxic, kill off more myocytes, which causes your cardiac output to fall, which causes more of these levels to rise, which is even more cytotoxic, and you can now see the downward spiral. And that is why heart failure kills you. And that is why it can never be said to be stable. So once you have a patient with, say, HFrEF, and even though that New York Heart won, they still have that low output, which will stimulate those neurohormonal factors to rise even more, to become more cytotoxic, and to continue that downward spiral. And hence, we break that downward spiral with the use of our medication. So we have to, that's where the medications come in. The diagnosis of that remodeling caused by these heightened neurohormonal factors is basically done by echo. We see an increase in cavity hypertrophy, we see the scarring, we see the fibrosis. So here's an example. A person has an MI. On the day of 1 week after the MI, the ejection fraction is 41. Notice the end diastolic volume is 137 mils. 3 months after, the ejection fraction falls. Notice the end diastolic volume is bigger because it has dilated. This is remodeling at work. This is slippage. This is the cytotoxic effect and fibrosis at work. This is remodeling. But we know that the medications which we have today are effective in modulating these neurohormonal levels. And this chart, which you're seeing, is showing, it's kind of a meta-analysis showing that the medications we have today, either singly or in combination, have varied effects in the reduction of mortality and the reduction in modulating the neurohormonal factors. But I want you to notice the ones which have the best effect. The ARNI, which is your Vemada, plus the beta blocker, plus your mineralocorticoid receptor antagonist, your aldosterone antagonist. That is even better than using an ACE inhibitor instead of your ARNI. And that is even better than using your ARB instead of your ACE inhibitor. But they all have effects. Once you start to get a person on one of the medications that affect the neurohormonal factors, you reduce mortality. You slow down that downward spiral. Notice at the bottom, the ACE inhibitors effect is significant, but ARBs by themselves do not have a significant effect, nor the combination of an ACE inhibitor and ARB. So on every level, your ACE inhibitor and your ARNI are your choices above the ARB. Do not use an ARB alone in your heart failure patient unless they're intolerant of an ARNI or an ACE inhibitor. And your guidelines have it. The use of ACE, class 1, the use of beta blockers, class 1, the use of the mineralocorticoid inhibitor, class 1, and now your SGLT2 inhibitors, class 1 indication, and your ARNI. So today in managing your heart failure patient, we have what we call your 4 cornerstones, or as Europeans will call it, your 4 pillars. Your heart failure patients with HFrEF should be on these 4 groups of medications unless there's a contraindication. They should be on an ARNI. If they're not on the ARNI, which is your Vemada, should be on an ACE inhibitor. Or if can't be on the ACE inhibitor, then you use your ARB. If they can't be on the ARB, you use a hydralazine isoardyl combination. They should be on a beta blocker. They should be on an aldosterone antagonist, spironolactone or eperinone, and they should be on an SGLT2 inhibitor. What? Yes, these are your cornerstones. All your HFrEF patients should be on these four, unless, as I said, there's a contraindication to one of them. For example, the blood pressure may be an issue. They may have high potassium, so you can't use the MRA, but there has to be a reason. And outside of these four, we even have new drug therapies coming about, which I just touched on a couple of them, which have undergone clinical trials, and I mentioned them, but they are not part of the four pillars or the four cornerstones. Will one day become 5 or 6? We will see. Pillar 1, the ARNI. I'm not going to talk much about this. It was talked a bit earlier. We have heard about how the ARNIs have come about. We have added the sacubitril or the neprisilin inhibitor to the valsartan. So isn't this a bit confusing? I told you ARB should not be the first choice, yet the first choice is an ARB, but it's not an ARB by itself. It is an ARB with a neprisilin inhibitor. Let me explain. ACE inhibitors have always been the first-line choice above the angiotensin receptor blockers. And without getting into details, one of the things that ACE inhibitors do, which ARBs do not do, is increase your bradykinin levels. Yes, the bradykinin that we think is the cause of the ACE-induced cough. But bradykinin does the opposite of what angiotensin 2 does. It's a vasodilator. It increases natriuretic oxide. It causes increased natriuresis. It goes against the cytotoxic effect. So there are some people who actually believe the strength of ACE inhibitors is not that they inhibit angiotensin 2, but that they increase bradykinin. Now, your ARBs do not increase bradykinin. But as you see here, bradykinin is broken down by neprisilin. So what the ARNI is valsartan, which inhibits your angiotensin 2 at the receptor, plus a drug that prevents bradykinin from being broken down because it inhibits neprisilin. But neprisilin doesn't only inhibit bradykinin. I mean, neprisilin doesn't only break down bradykinin, it breaks down substance P, it breaks down atrial natriuretic peptide, it breaks down B natriuretic peptide, it breaks down other factors which are also important in counteracting the effects of angiotensin and aldosterone. So when you add sacubitril, you increase your levels of bradykinin, substance P, you increase your atrial natriuretic peptide, you actually increase these back to normal levels, which are actually low in your heart failure patients. So you are attacking it by two areas. Essentially, I consider ARNI like a super ACE, because while the ACE inhibitors increase your bradykinin, the ARNI increases bradykinin plus the other useful factors. So notice, this is the key to the success of your ARNIs. And so the studies have shown that it reduces mortality even better than the ACE inhibitor. And it's no surprise, because it's not just bradykinin you're increasing the other factors. And as a result, one of the things we see is a fall when you measure your pro-BNP or your BNP levels. Remember what I showed you happened with remodeling. These levels rise. So we now know that it affects remodeling. And so we have studies which show that under ARNI, your ejection fractions improve. Your left ventricular end diastolic volume index goes down. What does this mean? Your heart gets smaller, and you improve ejection fraction. And so the ARNIs have been proven to reduce remodeling, as do your ACE inhibitors, but they do it even better. And it doesn't matter which dose. We know you want to get your patients up to 200 milligrams twice a day of your Vemada, but some can only tolerate 50. Some can only tolerate 100. What this chart is showing is that irrespective of which dose you're using, once they're on it, you get some improvement. You get some reversal of your remodeling. I don't have time to go into all of it because I know I'm going. Beta blockers, pillar number 2. The important thing I want to emphasize here is to use the guideline-directed beta blockers. All beta blockers are not created equal. The studies for heart failure are with carvedilol, metoprolol, and bisoprolol. And they're the ones to use, not atenolol, not propranolol, not nebivolol, not labetalol, because we don't have the studies to prove this. These are the 3, and if you look on the studies, the beta blockers make a remarkable difference in mortality in your heart failure patients. And of course, one of the things we look on is to look on the heart rate, because of course, we say the patient is adequately beta blocked when the heart rate is in the 60s. And the studies have shown that the patients whose heart rates are above 70 have a higher mortality. And that is what essentially this is showing. And if on the beta blocker alone, you cannot get it to that lower heart rate, could be because of blood pressure or some intolerant side effect to the beta blocker, add ivabradine once they're in sinus rhythm. Remember, ivabradine, you cannot use it in persons with atrial fib for a simple reason. Ivabradine works at the ISC receptor in the SA node. So if your heart rate is not being driven by the SA node, it's not going to be helpful. And the studies have shown that the combinations of a beta blocker and ivabradine may actually be better than just using beta blockers alone. And the effect on remodeling is even greater with the combination. So don't be afraid to combine them. And as they showed, you have the 18 inhibitor plus beta blocker, and you add the ivabradine, the change in the left ventricular end systolic volume index is even greater. What is it saying? It causes greater remodeling. A Canadian study actually showed that ivabradine does more than cause remodeling of the structure. It causes remodeling at the level of the mitochondria, which is the energy, the engine of your cells. So imagine there are effects which we are still yet to discover. Pillar number 3, the mineralocorticoid receptor antagonist, or your aldosterone antagonist. So spironolactone, which has been shown in the RAIL study, and we have eplerenone, which has been shown to reduce death from cardiovascular hospitalization, all-cause death compared to placebo. So either of them can be used, but the advantage of eplerenone is that for your men, they don't get gynecomastia. So don't give the women bigger breasts, hush guys. But for the guys, it prevents the gynecomastia. But the thing there are several things to look out for, because I know sometimes people are afraid to use these drugs. Well, guess what? Low blood pressure is not a reason not to use them. At the dosages in which we use spironolactone up to 25 milligrams, do not go above 25. And eplerenone up to 50. There's very little blood pressure reduction. I have started these on patients who have systolics of 80 and 90 millimeters of mercury, because I can't use the RNA, I can't use the beta blocker. I need something to affect the neurohormonal. I use this, and over time, I actually see their blood pressures improve to the point at which I can now add a second cornerstone or a second pillar to their management. Yes, you have to watch their potassium, but once the potassium is not above 6, you can continue with the lower dose. If it goes above 6, you should stop, get the potassium down, and then restart at the lower dose. Pillar number 4, the SGLT2 inhibitors, which we know came about as anti-diabetic medication found in the diabetics to help cardiac outcome. And this has been shown in the different trials, the EMPEROR trial, the DAPA heart failure trial, that the diabetics definitely did better. But guess what? The non-diabetics even did much better. And the fear people have, but it's a diabetic medication, I'm going to make my non-diabetic hypoglycemic. Here's the joy of it. It doesn't. Your non-diabetics don't become hypoglycemic on a drug that lowers sugar in your diabetics. Isn't that amazing? Not only is it amazing, they benefit even more in terms of their outcome with heart failure. And again, the studies have shown the SGLT2 inhibitors actually affect remodeling. And we also know that as you heard earlier, they help the kidneys and has been warned. Unfortunately, if your GFR is below 30 or below 20, depending if you use dapagliflozin or others, you cannot use it. So you do have to monitor, and it can have a mild hypotensive effect. It is mild. So again, if the systolics are like in the hundreds, low hundreds, you may be able to add it and moderate and see how they do. The things to consider, some of this was already mentioned, so I'm not going to go over all of this, but you do have to watch for the DKA, and the fear they had about lower limb amputation was only seen with one of them, which is not even the main one, which we're advocating in terms of heart failure, but can still be used. And again, once they have good lower limb care, the risk of that is extremely low. But hypoglycemia is not an issue. I have many of my heart failure patients on the SGLT2, not one has suffered hypoglycemia. So we also know that the RNA and the SGLT2 effects are additive. They can be added together and they should be used together. So how do I start my 4 pillars or my 4 cornerstones? Well, we are moving away from the idea, start with one, then after a few weeks, add the next, then after a few weeks, add the next. No, start with 2. And I think that's a clinical judgment. You have to look on your patient and see what can be done. You are told beta blockers, the patient should be dried out before starting the beta blockers, but the RNA actually works better on the quote unquote wet patient. So you can add the RNA and the SGLT2, because remember, the SGLT2 also has a diuretic type effect. And then after you have stabilized them on that, you then choose the next one, depending on their heart rate, their blood pressure. So you have to look on the individual. As I said, I've had some because of the blood pressure. The aldosterone antagonist is the first one that I've used. And then I'd add something else. If they're bradycardic, you know the beta blocker, it cannot be added. So you decide which one. It's on a per patient. But the aim is, if they can, after 4 weeks, they should be on all 4 drugs, unless there's some contraindication to that. So the strategy for your management of your HFrEF patient is to get them on the 4 pillars, the 4 cornerstones. And you will have some patients, well, even before I come to that, let me tell you guys, they work. I have had patients walk into this very office that I'm sitting in a New York Heart 4. I start them on their diuretics. You always have to diurese your patients, but diuretics do nothing for mortality. Diuretics do not affect remodeling. And I start them on 2 of my pillars. I bring them back a few days after to see how they're doing. And then eventually, in a matter of weeks, I have them on all 4. I have seen ejection fractions go from 20s to the 40s. I have seen the heart sizes come down. I have seen it all. I have seen the reverse remodeling really right before my eyes. As you do sequential echoes, you see the reversal of the remodeling on the patients once you get them on these medications. I've had patients who couldn't walk, now able to take the bus, move up and down, back to work because they have been on the medications. And this is without admitting them, but you have to follow them. Of course, there are some you have to admit, and there'll be some who, despite being on this, they're still going to be symptomatic. So their role for other medications, very Sigwat is a medication which the studies have shown can be added to your 4 pillars. And it lowers the risk of rehospitalization, and there are studies looking to see if it reduces remodeling. But what it is a soluble GC stimulator. It is a soluble cyclic guanosine monophosphate stimulant. Just to say that, let me just quickly explain this cartoon. When you have low nitric oxide, you don't tend to stimulate your soluble guanosine cyclase, and that decreases GTP to cyclic GMP, which it provides energy for your myocytes. So very SIG-Watt comes in and stimulates it to get you producing more cyclic GMP, increasing energy and contractility of your heart. Essentially, that's what it does. And they do have evidence that it affects remodeling. So where does it fit in? On the patients with the 4 pillars, still symptomatic, then it is something that you will add. And I'm sure over time, you will learn more about it. It is just entering the Caribbean market, so it's not fully here yet, but it is in use in areas of North America and Europe, and especially useful for persons who BNP are above 8,000. Let me tell you, I monitor BNP in my patients, pro-BNP, and again, that is something I've seen on the 4 pillars, and that's why I'm telling you, I'm excited. I've seen people with pro-BNPs above 9,000 come to have pro-BNPs below 1,000, and that is very remarkable for what we're doing. Another drug on the horizon, omecamtiv, which is a selective cardiac myosin activator. Just this one explains it. Those movable parts of the muscles which hold and pull to cause contractility, what it does, it enhances those myosin heads. So without it, because of slippage, you have less heads holding, but on it, you have more heads holding. So it helps to prevent the slippage and to get the heart syncytium back into correct position. And so you can also anticipate that it should help remodeling. I just want to close, I'm almost at the end. There are also devices which are used to help for those patients who, despite being on guideline-directed medical therapy, who are still symptomatic. And you're going to have those. You know about resynchronization therapy. You can talk about things like left ventricular assist devices for those who are who need transplant. You have transplant. But one which a lot of people don't know about is what we call cardiac contractility modulation therapy. This is a device which stimulates, which gives a charge to the heart and causes improved contractility. It's not a pacemaker. What it does, it provides that electrical stimulation in the refractory period of contractility. So that is immediately after the QRS, which you can see here. And it doesn't have the effect immediately like you put it in today and ejection fraction improves tomorrow. No. It starts to work locally in a matter of hours, and it starts to have widened effect over the weeks. And in a few months, you do have improvement in ejection fraction, you do have reduction in LV size, and you have improvement in 6-minute walk tests. Who benefits from this therapy? Or persons with New York 2 and 3 who are on guideline-directed medical therapy and whose ejection fractions are between 25 and 45. So you're talking about the HFrEF to the Mr. F. Why not below 25? Because the studies show they don't benefit as much. It seems as if by the time the ejection fraction gets below 25, the myocardium is too far gone to benefit from this therapy. And it is for those who do not benefit from resynchronization therapy. That is, resynchronization therapy is for persons whose ejection fraction is below 35, but whose QRS is greater than 120, actually better, greater than 130. So they have a wide complex QRS with a low ejection fraction. But we have many heart failure patients with low ejection fraction with a narrow QRS who will not benefit from resynchronization therapy. CCM is a therapy which they can use, and we do offer it here at PICJ. So what about diuretics? This is my second to last slide. What is new in the guidelines for diuretic patients is that the addition of a thiazide-like diuretic to your loop diuretic is now a 2A from a 2B indication. And so if you're not getting adequate diuresis with your loop diuretic alone, go and add that thiazide-like, go and add that metallazone, that indapamide to help with the diuresis. So overall, the management of heart failure, get your patients on your cornerstones plus your diuretic. If the ejection fraction is below 35 and the QRS complex is less than 130, you may have to put in a defibrillator. And if the symptoms persist, you may not have to consider other therapies such as CCM, contractility modulation. If they come out of the HFrEF into the HF-MR-F, if they remain symptomatic, then things like CCM may play a role. And of course, if they have the widened QRS complex, then biventricular pacing maybe is an indication. But if they improve on the 4 cornerstones, then you are doing the job. And just remember, one size doesn't fit all. You have to still look on your patients, make a decision as to how to use all of this therapy. So every clinician needs to know and consider that the foundation medical therapies are there to improve HFrEF. There are additional drugs and devices that are there, some coming on the horizon, and surgical intervention. But we must ensure that all patients with heart failure are seen by a cardiologist or someone who is an internist who has had experience, should be seen early, referred early, start therapy early for the best outcome. Thank you.
Thank you so much, Dr. Elliot, for your vibrant and excellent presentation as usual. And I do have a question in the chat. In terms of prescribing medications such as Vimada, should initiation of this treatment be done primarily by the cardiologist and the specialist in internal medicine, or should the general practitioners be able to prescribe this medication?
Well, the aim of this talk is really that we want the GPs eventually to feel comfortable doing it. So you don't, I mean, if you have a patient with New York 4 or 3, then yes, you may want to make sure they are on the proper guidance and supervision. But if you have a patient who has HFrEF or HF-MR-F, and Vimada is advocated for those patients, and so you should feel comfortable to be able to start, even though some islands and places may have prescribing limitations depending. But if there's no such limitation, the aim of talks like this is to tell you that, yes, you can start your patients on the 4 cornerstones.
Thank you so much. At the moment in Antigua and Barbuda, the cardiologist and the internal medicine specialists are who are allowed to prescribe the Vimada at the initiation point.
Right, and eventually that's going to change over time, but you'll find in some markets it is like that.
Excellent presentation. Some feedback from the chat. Someone comments your breaking down of this topic, making it very simple to understand. Will the PowerPoints be available? Yes, we are arranging to have it on our site and all of the presentations. Well, this entire symposium, you'll be able to access to fill in any gaps and look over it whenever you need. We're hoping to have it posted up by this weekend or latest later in the week.
Sorry, can I just make 2 notes? So again, just to emphasize, the key thing is to refer early, especially if you think your patient needs things such as added devices. I know Dr. Mead is a cardiologist. Let her see, let her assess. She communicates with me about some patients and referrals. Laurie Ann Henry, it is good to see that you're here. Sorry, she's a classmate of mine. I have to big her up. I need to get in touch with you. So get in touch with me somehow, please, Laurie. But it's good to see her here. God bless you. It's been a long time. Sorry, I had to put that in.
Dr. Winter has a question.
No, I just want to say, Dr. Elliot, you were superb.
Yeah.
We have
Thank
lectures here all the time, and you taught them. I really have to say that to you. It was excellent. It was all inclusive. You did a fantastic job. One thing I'd mention, what about heart failure clinic? We have them here and they function fantastic. They work very well. What about the heart failure clinic, Dr. Mead in Antigua? It's run at the hospital level. What do you think, Dr. Elliot?
All right. And then Dr. Elliot.
In Jamaica, we have, I think, 2 heart failure clinics, nurse, basically driven by nurse and pharmacists. One at the university, and there should be one at Kingston Public Hospital. Even in my private setting here, I'm hoping to establish that kind of separate arm, because you're right. You see, these heart failure patients, when they get that kind of focus, they do better. Because we're talking about medication, but that's just only one aspect of managing your heart failure patients. You have to manage the psychological, the emotional, the sexual. I looked at a heart failure patient who can't have sex is a depressed patient, and depression worsens heart failure, and that worsens depression. You know, you have patients coming about it, and sometimes us as physicians, we don't always have the time to deal with that. We sometimes have to deal with patients. Like I had a patient once who, for example, a patient who was once in charge of, basically he was once a powerful man. And now his old and illness has now made him no longer powerful. But that has psychological effects on him, that this disease has crippled him. And just by talking with him, he gets angry at time. And of course, he takes it out on his wife, not physically, but you know, he snaps and so on. And just by spending time talking, I was able to help them both to focus that, look, he's not angry at you, he's angry at what has happened to him. So he has to learn to work that out. So he stops snapping at his wife, and his wife can feel better being around him. And so that psychological heart failure affects so many different things. And that is why you need the psychologist, psychiatrist, the dietitian, the physiotherapist. All of these people play a role in the managing of heart failure. And yes, a heart failure clinic, therefore, is something which is not just needed, it is necessary.
Absolutely.
I do agree.
We have actually, there's a heart failure clinic at most of the hospitals here in Montreal, and they really work very well. What Dr. Elliot just said is it's really true. You need all these people to help the patient with all these issues. And I think the heart failure, as a physician, as a cardiologist, you don't have that time to do all these things. So that the heart failure clinic comes in to help the patient in many respects, in all these avenues. The cardiologist serves as a consultant to that group.
It limits the presentation to the emergency room, because what's happening now, they just go back to the emergency room once they become.
That's correct. It increases the cost of healthcare.
It does.
Again, Dr. Elliot, you were superb. I give lectures here and I go to them. We have lots of CMEs here in Canada, well, here in Montreal, and you were really outstanding. Really
Thank
outstanding.
You.
Very.
I'm humbled by your compliment.
Thanks. And one question, the RNA use in patients with preserved ejection fraction, the present guidelines of that.
All right. RNA has not been indicated for it, even though there is a study which has been, there are 2 studies which have seem to indicate that there's a group of patients who seem to benefit. The studies did show an improvement, but not statistically significant. But when they broke it down, they found there seemed to be a handful who seem to benefit from it. And they're trying to understand who are these persons. The SGLT2s are now FDA approved for HFpEF. At least one of them, empagliflozin, has been FDA approved because there are no studies showing that they benefit HFpEF. I tell you, I do have about 3 patients who, as a last-ditch effort, who have HFpEF, who I did put on an ARNI, and they improved. They absolutely improved. Not all my HFpEF did, because I tried some others and didn't, but I have 3 who functional capacity improved dramatically. Their edema is down, they're functioning, and they have HFpEF.
Thank you. Some more congratulatory and well done comments. Any more questions?
HFpEFs are very difficult to treat. We see them all the time in the ER. They're usually elderly women who presents with acute pulmonary edema, and they return to the hospital all the time. It's a very difficult subset to treat.
Thank you. Another question from Dr. Joycelyn Walter Thomas. Besides congenital heart disease in the pediatric population, are there any current recommendations for screening for heart failure in young adults?
Sorry, repeat the question.
Besides congenital heart disease in the pediatric population, is there any for screening for heart failure in young adults?
Well, remember, there are different things which affect the heart apart from congenital issues. Very rarely there's ischemic heart disease. We do know about Kawasaki, which can affect the hearts of children and even eventually into adulthood. So I would say you just have to do a screening beside what you do clinically, examining your patient. I know in the pediatric group, they may not always present with the congestion, and the pediatricians can tell you a bit more what is it they look for to say that you have heart failure. But just remember what I showed you. You have the different stages. If the person is a stage B, which is basically at risk of heart failure based on whatever disease they have, then those patients you should be just monitoring, checking. They could be post-leukemia and had to get chemotherapy. So you wonder if the chemotherapy has affected the heart. Could be thyroid disease, hypertension in the young. So for these, you would monitor, you would screen, but not just every child out there that you do that.